Hi, my name is Maggie Jalowski, and I'm the Director of Advocacy with Sickle. Today, I'll be talking about how we work to center the patient voice during Medicaid and Drug Utilization Review Board meetings. We'll start with some background information. Our programming at Sickle works to improve access and coverage for sickle cell patients. So we hone in on insurance programming and work to understand how they're impacting individuals with sickle cell in the way that they're able to access and afford therapies. We specifically look at Medicaid programming since we know that the majority of sickle cell patients receive coverage from Medicaid. And additionally, it's a really important program that can act as a safety net for some of the most vulnerable members of our community. And so through our advocacy programming, we really focus on state and federal policy decisions that impact Medicaid and impact the way sickle cell community is able to access therapies. This slide looks at some background information about the prevalence of sickle cell across Medicaid programming. 42,000 individuals are with sickle cell are on Medicaid and CHIP programs. The map here shows distribution of where geographic variation across the country of where sickle cell patients on Medicaid programming live. And you'll see that the dark blue states indicate the highest prevalence of sickle cell. So those are in Louisiana, Mississippi, Alabama, Georgia, and South Carolina. And then the box here with 3 indicates it looks at state level data since without national prevalence data, state data collection becomes really important as well. And so this was across a 3-year period that showed 66% of individuals living in California with sickle cell disease were insured by Medicaid program for at least 1 month. So again, this shows the importance of Medicaid across the sickle cell community. One of the most common forms of utilization management, or a tool that payers and insurance companies use to try to control drug costs, is the preferred drug list, the PDL. And this is where there's a distinction between preferred medications versus non-preferred, where the non-preferred medications typically are more expensive, or they may require prior authorization or step therapy. Ultimately, the individuals in Medicaid that are making these decisions are either part of the Drug Utilization Review Board, so the DRB board, or the Pharmacy and Therapeutics Committee, PNT. And so these are the 2 bodies that we work to do with our advocacy work so that we can help improve access and coverage for these preferred drug lists. So through our ambassador program, we activate a local network of advocates, providers, and nonprofits in the states. And ultimately, we have these 6 aims. We are working to affect positive change in state Medicaid coverage, promote the patient voice, build relationships, increase access, and educate local advocates about how they can be working at the state level in their own states. The image shown on the right is a toolkit. You can view similar toolkits on our website, and this talks more about how advocates can get involved in this work. Here at Sickle, we have a 5-step approach to advocacy at the DRB meetings. First, we work to understand when sickle cell treatments will be reviewed in each state. The second step then is to conduct outreach. We reach out to local advocates, we reach out to Medicaid meeting coordinators, we learn more about how these meetings are going to be conducted and what the process will be. The third step is to organize a planning meeting. This is an opportunity to have a conversation and to organize our testimony so that it's most impactful and powerful. The fourth step then is to either provide written testimony or register local advocates so that they can provide oral testimony the day of the meeting. And then step 5 is to attend the meeting virtually and conduct any follow-up. The box on the right here highlights some really important takeaways that we would like to share. First is that the frequency and the procedures for each of these meetings vary across the state. So it's really important to understand exactly what's happening in your state. We have an advocacy state map that Abby will actually be talking about today. And this can be used to find links about meeting schedules and other information about DERP meetings in each state. Also, it's really important for advocates to incorporate data in their testimony. We look at drug utilization data, so how many individuals on Medicaid program are already accessing Medicaid treatments for sickle cell. And then, of course, the state prevalence data as well, which was some of the background information I had shared. It's also important to understand where current medications exist on the PDL. Are they currently listed as preferred or non-preferred? And then finally, the most important piece is this advocacy work is important not just to advocate for the PDL, but to build relationships. As new treatments become available for sickle cell, this process of making these decisions will keep being important. And it's important for advocates in the state to build these relationships with Medicaid staff. So this shares some of the results and discussion that we have. To date, we've attended or prepared advocates in 10 different states, and this map shows the states below. We've worked with 26 advocates, 5 medical or higher education institutions, and 6 community-based partners. And so I want to take some time right now to just thank all of these individuals for their hard work and advocacy. We are really just facilitating the work, but it's ultimately these individuals that are on the ground, sharing their testimony, sharing their stories, and making the impact. Some things that are important to highlight is that many of these committees do not have individuals that have the expertise in sickle cell. And so this becomes really important for these advocates to act as a subject matter expert. They also do not understand the specifics of the therapy or the mechanisms of action. And so that's where we found that clinicians with experience with these therapies can really make an important impact in these meetings and talking about how these therapies are important for our community. Additionally, there's a lack of transparency in the decision-making process. It's often not clear and the discussion is not transparent why some medications remain non-preferred and others are preferred. And that's something that we are working to promote, and we hope that through this work, Medicaid programming can become more transparent. Additionally, of course, there's limited data that is really needed to make an impact, specifically looking at the impact of prior authorization and how that impacts access and utilization. We also noticed that state advisory committee boards are not being consulted, which is a major finding. And so we encourage all local task force that are involved in Medicaid programmings to reach out to their DERB and PNT committees and can be looked at as an expert or source of information for them. And then finally, we found that many of these boards are utilizing ICER recommendations without really considering the societal perspective. And so that's something that we work to do for them to understand the societal perspective of ICER. So in conclusion, we will continue our work to build these relationships across the states. At the end of the year, we'll be sharing a best practices that came from our work, and we hope that this will help advocates engage with their Medicaid boards in the future. And then finally, if you're interested in becoming involved in this work, please sign up to be an ambassador in our program. More information about this program is on our website. Thank you so much for this time.